Broadcasting live from the Business Radio X studios in Pensacola, Florida, it's time for Pensacola Business Radio. Now, here are your Business Radio X hosts.
Hey, good afternoon, everybody. Keith over here, broadcasting live from our studios down here in Pensacola, Florida. And it's almost Christmas, so this is technically like the last work day.
Ooh,
you know,
nice.
I think
Nice.
before next week, right?
I think so. Yeah, most people won't work Monday.
Yeah. You're going to work Monday, though, aren't you?
I probably will.
Yeah, I figured. So we're going to talk today about all kinds of movement and motion and therapy and rehab and CrossFit, and I'm sure some other subjects too, but Justine didn't know about them yet, so we won't talk. No, I'm just kidding. But I'm going to let our two guests introduce themselves. So, Justine, by all means, please, go ahead.
Hi, it is Dr. Justine Williams, pelvic floor PT and owner of In Her Physique, pelvic floor physical therapy and wellness.
Yeah.
Gosh, that was
You're
a lot.
You're going to have to practice that.
Oh, my God.
Yeah, you need an acronym for sure.
It's so long. Yeah, so that's me.
That's right. You're new to this, you know?
Yeah, true to this, though.
Yeah, there you go.
Ooh, that was fancy.
She's been waiting all day to use that one.
Yeah, for sure. My name is Dr. CJ DePalma, physical therapist. I am owner-operator of The Movement Doctor, a cash-based PT clinic here in Pensacola, Florida, specializing in pain management and high-level athletes,
he's done this
rehab
before.
and injury.
Write it down. Write the script and just practice it over and over.
Elevator pitches, you need them.
Yeah, less than 30 seconds.
Less than 30
Right.
seconds.
There's so much I got to teach you.
Oh, my
it is.
gosh.
It is.
Go on me.
This is why you're hiring me.
He's just building his resume.
That's it. So, okay. So let's, for those that don't know what you do and why you're sort of unique to this arena, give them a sort of a rundown.
Okay, so pelvic floor physical therapy is not by far new at all. It's a form of rehabilitation that has been around for a really long time. People just don't know about it. One, because of what we do. We treat the pelvic floor, which is an internal muscle. You know, if you don't go to the OBGYN or, you know, a urologist or something like that, you probably won't, you know, know much about this area. So, you know, it's private. So we treat it.
You don't think about it until you have a problem there, right?
Exactly.
Yeah.
Don't think about it till you have a problem there. So I think that's why, overall. So we do pelvic floor stimulation for dysfunction. So if you are a pre or postpartum mom who has leakage, if you are a male who needs surgery on your prostate, pre or post-op, if you are a kiddo who's, you know, experiencing bedwetting or accidents at school, we treat it all. So anything that impacts that area.
Huh. Who would have thought?
Yeah. It's from an outside perspective, a lot of people, it's just generally very believed as taboo.
Yeah.
So people are very embarrassed to admit that they have issues.
It's not the first thing you want to go telling everybody.
Right,
Right.
exactly.
Yeah.
So, you know, people hide it like, oh, it's not that bad, or
Right.
post-pregnancy moms or postpartum moms, or, oh, it's normal, it's postpartum. It's not normal, you know, and that's what I think is very important to understand, especially for the people who know me and the people I deal with CrossFit athletes or just athletes in general that do a lot of jumping, running, lifting. Females leak all the time,
right?
With general stress incontinence, and Justine is very capable and well educated to manage that.
Thank you so much.
So there you have it.
Yeah.
Okay. So and you said cash based when you were doing your 30-second elevator speech, right? And so I know both of you are cash based, and I know that's a different thing in this arena, right? Because most people are used to insurance companies and being all done. Not that you can't get reimbursed by your insurance company for some of the stuff that you all do, but it's cash based. It's cash up front,
right?
So I know you got some struggles and some hurdles with that, but why do you two choose to do it that way?
You want to go first, Siege?
You can.
Okay.
My answers are always going to be way longer, so I'll let you cover the most part of it.
I choose cash-based, one, because I went to school for a very long time.
You got bills to pay.
I got bills to pay. But, you know, I went to school for a long time for an insurance company to place a number or value on what I have to offer to my patients. And I think that is my number one reason, after working in a plethora of settings, from outpatient to inpatient hospital to skilled nursing facility. It's you against the clock. It's not you and your patient entering a relationship so that they can get the best quality of care. It's how short duration can I be with the patient and get the most money out of it. And I don't operate that way, especially with my particular niche. I need to build a rapport. So that's why I chose cash-based.
Okay. So your treatment methods are a little different.
Right. They're different. They take more time. So,
all right, CJ, we're all on edge.
So Justine makes a good point of like insurance being our limiter, to the point that it is putting a number on like they're valuing our care, we're not creating our own value at all whatsoever. And with more PTs graduating, insurance, the healthcare reform being as terrible as it was, it's just reducing reimbursement rates. So the same hour is not what it was even worth in 2000.
Yeah. Right.
Well, guess what? The dollar isn't worth what it is in 2000, but in an inverse relationship, right? So we're not getting paid as much per hour, or people accepting insurance, but we're having to see more patients. So the more patients you have to see at one time, quality of care reduces. I think some PTs do it very effectively. I was not one of them. Mm-hmm. I struggled a lot with seeing 3 or 4 people at a time because I like to just talk nonsense and have a good time and create a good, comfortable environment.
Yeah.
And you can't do that when you're like yelling at someone across the room, like, hey, that looked good, pull your arms back or whatever. And one-on-one care, I believe, is just more effective.
I think it's the only care that's effective in y'all's world, right?
There is, and I try and be very political in a lot of my answers.
Speak it like it is, man.
So, but yes, I believe personally that one-on-one care is really the only way to go. But secondly, cash-based PT is a much lower overhead for us startup businesses.
Right.
So you want to open a physical therapy clinic, accepting insurance, you need billing, you need front desk, you have to get accepted by Medicare. Those things take a lot of time and they take a lot of money.
Process.
And you can also get denied your claims. So you can
do the work and then never get paid for it.
You can treat $100,000 in patients in 6 months and then get denied all of it because you didn't get your Medicare ID number. Those things happen. And that would just end someone. It's a big risk. Yeah. So with the cash-based setting, we don't have to worry about that, right? We're marketing ourselves, but at the same time, we have much bigger risks and challenges on our own end trying to find patients. We're not getting sent anyone. Most physicians or surgeons or pain management clinics will not send us patients because we don't accept insurance. So we have to lobby for ourselves much harder.
Yeah,
absolutely.
So, and do you guys think that insurance companies would also sort of limit your ways of care, your ability to?
Oh, yeah, correct. So we're treating based on what they will reimburse. So
so instead of the problem that's actually at hand, you got to deal with what category you can fit it in.
Yeah, if they come in with diagnosed cervical problem, but you see that they've got a lower extremity issue, like you aren't technically allowed to. You have to
treat that.
You have to almost I wouldn't say fraud, but you have to really reword your notes appropriately to deem that their lower extremity problem is something that can be addressed while addressing their cervical problem. When that cervical problem might not even be that bad. It might be something else completely.
So now you're just setting people up for failure, right? I mean or they're setting you guys up for failure.
Yeah. And the patients.
Yeah. So, so you mentioned some challenges with getting some clientele and really getting people to understand that you guys work differently. What are some of those?
Oh, where do I begin? So I think it's marketing and letting people know that they have the option to come to us and understand that, or what the comparison is between paying for insurance versus coming to a cash-based provider. Mm-hmm. So I look at it like, okay, we don't want to bash these companies in our area, but we also want to advocate for what we bring to the table.
Right.
And that boils down to education. It's like, okay, this particular service that I provide for you for an hour versus what, you walk in and pay your copay and what you get there. And sometimes it just doesn't, we are, led by our wallets. So it's like, okay, how do I, explain this in a vernacular that you will understand?
Yeah.
So does that make sense?
Mm-hmm. So how are you? So you have to educate, right? You need to tell them why you're doing what you do and why it's different, why it's better. I totally get that.
Which takes a lot of time.
Sure.
It's not something that's a quick turnaround.
Yeah.
And unfortunately, education is not a billable.
Right.
Yeah.
It's not a billable intervention.
And how many people glaze over within 10 minutes?
Well, when you're doing it in traditional, that's the goal. Is like we have to keep them
entertained, right? And
so it's tough to do that. You're like, oh, you evaluate them, and you're like, oh, you've got this, and you start going down this very biological or mechanical explanation. They're like,
yeah, you kind of nerd out.
I'm in pain. I'm in pain. Fix
Make it stop.
Right, but with our setting, a majority of the time, my whole first hour in evaluation with someone is just talking. just talking about their issues, their history, getting listening appropriately. I don't have to do an evaluation in 15 minutes. I can take my whole hour. I can spend an hour and a half. I can spend 2 hours if I need to.
Yeah.
I'm not limited by those
How
things.
much more do you guys find out from just having conversation with people than you ever get on the form?
A ton.
Yeah.
And it's just because the form is so rigid. You know, there's no room for adding anything. So, and I think that's what I value the most with cash based is being able to have that conversation and actually have time to process what they're telling me.
Right.
Because really, like, let's
I
say,
didn't even think about that. You got the backside of it too.
Right.
Yeah.
Because it's like, okay, you're against the clock. Let's say we have 60 minutes for our evaluation. You know, we try to fit like 15 of those minutes for your evaluation for me to talk and say, okay, what's really wrong with you? Okay, I think I've seen this before. Whereas like if you come in and sit down, it's like, wait, it's a little bit more to it than that. It's a little bit more than like, hey, I have rotator cuff issue.
Right. And then
whatever.
And then turn around.
I'm just saying, I'm coming to your.
But you're right though. But then turn around and process all of that and really start thinking about the best mode of treatment within that hour is not. Yeah, it's not effective.
It's not a cookie cutter, treatment style.
Right.
Yeah.
And then, so the biggest thing that I see is like, so we were educated. We're diagnosticians. That's what we're taught to do. Diagnose. Well, the research shows that our ability to diagnose is horrendous across the board.
Yeah.
Like to diagnose.
To diagnose or to misdiagnose?
No, to diagnose.
Yeah.
We misdiagnose all the time. But also on the same clock.
That's why it's called practice.
Right. Well, so, yeah, right. Health. Yeah. Yep. So.
Practicing medicine, baby.
That's right. So that was fair. That's pretty funny. But on the same clock, even when we do diagnose right, it doesn't matter. Treatments are the same. You have a shoulder issue. You have rotator cuff, labral, tendinopathy, something like that. They're going to be treated all exactly the same way. So it doesn't matter.
Right.
So it's not that important to diagnose properly, but it's very important to understand the history of someone's injury.
Sure.
Right. So
what they're going to do when they get home.
Well, their lifestyle, those
how they
things.
act, yeah.
So pain and injury and all these things have much bigger players than just a mechanical or structural reasoning, right? Stress, activity, lifestyle, those kind of things, what your doctor has told you, your preconceived notions, your genetics, all of those things play a role. And so the history is the most important part by far, more so than my ability to run some testing on someone's shoulder, because that testing has pretty much been proven to not be effective and not really show anything. So with a traditional setting, we can't have that kind of conversation at all because it's loud. Right. Most people don't open up as well, but in my care and my practice in the room, we joke a lot, we laugh, we get them very comfortable, and then things just start opening up. They start talking more. Right? Yeah. The first 20 minutes is them trying to explain what's going on, and then after 20 minutes of us going back and forth, then basically they reopen for another 10 or 15 minutes, and then the real story comes out. Like, oh, well, I gained 30 pounds this time last year.
Right.
And it's like, oh, my knees are now hurting. And it's, okay, well, you didn't tell me that in 20, and that definitely wasn't in your form. So those things play a role, right? Nothing might be wrong. You just might not be in the shape that you were. Right. You just might have some pain. So those are very important to understand.
So do you think a lot of the mistakes that would come from healthcare and treatment is because they don't get that kind of information?
And the time.
Yeah.
You are against the clock. Even physicians, like especially physicians, when you go, go for
you see the doc's in there 5 minutes, and you know he's doing the last piece of it because you're what's the nurse or no, what's the one that's not a doctor but can the PA, that one, and
you're just like you're not comfortable because you're rushed. Especially with issues that I deal with. I'll practice getting closer to the mic. But I was going to touch on what CJ said about like your perceived outcome. Mm-hmm. Studies show that the more positive thinking that you have towards your treatment, the higher your outcomes. Yeah. And, the quicker you will get better. Mm-hmm. And the longer you will stay better.
Sometimes even better if you just don't even know what's wrong with you.
Correct. Yeah. So no, ignorance is bliss.
Yeah, that's 100%. The truth. Yeah.
PTs, you will see active and like very fit physical therapists that have the craziest injuries. They're like some random thing. And I'm like, are you sure? They're like, yeah, like, the 1/3 sector of my bicep attachment point. And I'm like, huh? I'm like, why do you know this? And it's probably not. How come none of your patients have ever had this? Right. You know, so because ignorance is bliss, but like what she was going on, positive outcomes. So if someone's bought in, whether I'm right or wrong, my outcomes improve. Right. Whether I've like nailed exactly how to make this better. Because
they're hopeful and they think they're going to get better.
Positive. And because they're coming in, usually to me, they're not forced to come in. So it's because it's not a health insurance thing. It's cash based. They're very voluntary,
so motivated.
They're very motivated.
Yeah.
Same with the people that are going to walk into Justine's office over the next few years. And then also the research is just coming back to narratives, like how you speak to your patients overall.
Oh, yeah.
So if you come in and you're like, Justine's like, oh man, you're leaking real bad. That's not a good thing.
Yeah.
You don't say that.
Right.
Or someone comes in like, oh my gosh.
Yeah, you got to have some bedside manner.
Right.
Right.
Yeah.
But we laugh about it, but it's very true.
Yeah.
Every PT, every chiropractor, every physician, physician that just read an MRI, like you have the worst back. You have the back of an 80-year-old. What does that even mean?
Right.
I know
Thanks, by the way.
Right.
I know 80-year-olds that have more degeneration than you can even imagine that are 100% asymptomatic. Right. That have no pain.
And I know some 80-year-olds that could beat me in a race.
Yeah, exactly.
Right?
And, if you took a picture of their spine, they will 100% have degeneration. It's part of aging.
Right.
So
nobody gets out alive.
No, yeah, exactly. Right.
Right.
So those things are really important in like how we speak to our patients, and we're able to do a much better job of that in a cash-based setting.
Absolutely.
Well, that's cool. So time, it gives you guys time is what I'm hearing the most of. So, okay. So ideally, because you are cash based, obviously, other than having cash being a qualification, what are ideal patients to come see you?
It's funny because we have CJ and I have different clientele, but we bridge at one place, and I think that's people who have pelvic issues, right? But for me, my top three, if I were going to have three, what is
avatars,
avatars or something, one would be victims of sexual trauma.
You've been hanging out in your digital marketing too long.
I know.
That's not your job. You need to leave that for somebody else.
Good at it.
Okay, cool. Avatar, got it.
Yeah, we'll tell you who you market to, man.
That's it.
He knows.
Postpartum mothers.
Okay.
And, I say the female athlete, but I think, athletes are fun. So I'd say those top three.
So in any age range? Doesn't matter?
Any age range, yeah. My first client was a 5-year-old.
Yeah.
So it's... Yeah.
It happens.
It happens.
So you can be young and have these kinds of issues too.
Absolutely. You can be born with, predisposition.
Yeah. And so you kind of play in the same arena with the athletes and stuff too. So who's an ideal clients for you guys?
Well, it's funny. Athletes usually aren't at least not CrossFit athletes. A lot of them just don't need to do as much as they're doing. I just need to kind of govern their activity.
It's dude, drop 100 pounds. It's not going to happen.
Yeah. Well, it's I can almost what we would consider general supervise them, not direct. So I can modify their training and their workouts. I don't really need to see them that many times. They're going to get better if they just let their body heal because they're exercising enough and they're doing all the right things anyways. We check for egregious issues, but for the most part, they're just going to get better. The patients I really like working with, and I would really want to come to my office are chronic pain patients that are kind of on their last limb. They've been through the ringer. They've gotten shots. They're on meds, likely been, opioid managed at one point in time, surgeries, maybe worked, maybe didn't. Those are the patients that I have seen the most drastic success with because my approach is 100% different than any traditional medical care.
So what do you guys do? Because you don't prescribe painkillers and all that kind of stuff, right? So what do you do when you get a client that's like, yeah, I hear you, but I'm in pain, and so can I take something for it? We tell them Tylenol?
No,
we're not allowed to suggest.
Yeah, no, we don't. I would say I just
that was a setup, ladies and gentlemen.
Right. We didn't follow.
He's writing it down. Lawyer walks out of the back.
Right.
Game over, man.
Shut it down. I'd say we balance it out. It's so individualized, and that's what's so good about cash base is that we talk to you about all the moving factors around your care.
Yeah.
So if you are always on, if you've been on this prescribed medication, but it conflicts with what, we want to do as far as therapy goes. I use blood pressure medication as a, issue with my older population, right? So if you're on blood medication, blood pressure medications, your pressure fluctuates up and down. If your blood pressure drops when you stand up, I can't treat you because you will feel faint and dizzy. So then, we try to develop a relationship with your physician so that we can communicate and figure out what's best for you. Yeah. We advocate for the patient.
So okay, let me ask you this. How are you accepted in the physician world? Because I know that there's all kind. There's always conflicts between, and we don't have to get way deep. But I mean, are you getting a welcoming setting?
I am. I
CJ, not so much.
I don't know about CJ. I don't know, but I can speak for myself because they see more value in something that they. I guess, are unfamiliar with.
Yeah.
I think that sometimes like ortho PTs, I wouldn't even call them ortho PTs, but PTs that, you know, focus on orthopedics more than, I guess, isolated to the pelvic floor. It's kind of like they've heard this before. They've heard it all before. But with this, it's like, wow, like I don't know what to do to help this patient get better or this population get better.
Right.
I'd say that and then I remove the competition aspect because it's almost like, oh,
you're more of an accompaniment or a supplement too, right?
A supplement. So I don't think it's necessarily that. I also think that like the way that CJ and I are marketing ourselves, it's not like, I guess the icing on the cake, like you're saying, is a supplement, but I look at it like we are helping the patient get better, helping the doctor look better. Yeah. Have you ever heard, like, I don't know, CJ, if you've ever heard, like, hey, don't mess up my surgery. Have you heard that before? Like if a surgeon did a back or a knee?
Well, I don't get it referred from a lot of surgeons.
Okay, well.
So CJ's got a problem in that social area we're going to work on, but
I don't know.
Maybe you can teach him a couple of things.
Maybe he's intentionally doing that. I don't know. But yeah, they don't like you to mess, they don't like you to mess with their stuff.
Yeah.
So if we can help them understand it a little bit better, I think that works, and they're open more now to conversation.
Yeah. Well, and I like what you said. I mean, if you're helping, if ultimately the patient's getting better, then everybody looks good.
Everybody looks good.
Yeah.
Absolutely. They'll write reviews on
sort of.
Write reviews on Google and
that's right.
Stuff.
For me.
So CJ, tell me about your experience, please. I can tell you're dying for it, man.
So the biggest thing that I do is educate, and it's very important. And a lot of what healthcare, from rehab to physician, when it comes to pain, is just wrong. The research is refuting almost universally what we've been told for so many years.
Yeah, that's happening with a lot of things these days.
Right, well, I can only speak on what I know, and I know we don't really know pain, but I know it enough to talk on it socially, and the research is just like disproving everything, like anything like your hips are out of alignment, your spine's out of alignment, this degeneration is causing your pain. I'm on social media, selfless plug, my Instagram, The Movement Doctor. We're doing a 30 days month of myths, and it's pretty much everything you've ever heard from either your physical therapist. It's all different. Your core is weak, causes your back pain. So all of these things are just being disproven to not have a lot of validity with the evidence. So when someone comes into me, pre-surgery, and I'm like, what are you capable of doing? Like I put my arm, so we'll just say shoulder. Shoulder is just very common in CrossFit and the patients that I see.
Yeah. Those tires.
Those tires. Tires are actually pretty safe. Just keep it real close. So, they come in and I'm like, what can't you do? I'm like, well, I just can't snatch really heavy. I'm like, okay. And I'm like, what's wrong? Like, well, they MRI, I have a torn labrum. Well, the guy sitting in front of you, me, I have 2 torn labrums, and I do high level CrossFit every day. No pain.
And they're still torn.
They're still torn. They don't get better. It's not
they don't get untorn?
No, they don't get untorn. And I have no pain. I had pain for a long time.
Yeah.
But with proper progression, your body will adapt. You're not Nolan Ryan. You're not Drew Brees.
Right.
You're not throwing, so it can get better, right? And the surgeries, the outcomes compared to non-surgical are the same. Surgery is a little quicker. So sometimes it's people that just can't wait. So athletes have a much different
contract.
Right. Yeah. So they need to get back on the floor to make money, et cetera. So that's different. But when you look at like 1 year, 18 months, 2 years, a lot of surgeries that we get done, labral repairs, rotator cuff surgeries, meniscal repairs or meniscal intervention. And they're just compared to non-surgical. They're not, they're just, the outcomes don't change much.
Yeah.
Okay. And so with that in mind, I don't want anyone to go under the knife ever.
Right.
And then pain is a terrible reason to go in for surgery when pain is, now we're learning, is more of what we call a psychosocial or a biopsychosocial player.
It's there just as an indicator that you've got to be doing something different.
Right. And it's not, we once thought pain was always biomechanical. So like you have pain, something is structurally wrong causing your pain. And now we're learning that it's not. It's the psychosocial factors that are playing a much bigger role. Biological is still there, very important.
Right.
But it's much smaller in
the
grand scheme of things. It's not all in your head. No, we're not saying that. Don't say that. Don't say that. No, it's not all in your head.
The thoughts here are not supported by.
No.
The major players in pain research now, like they all have started like blogs and things that like headlined, it's all in your head.
It's not.
Yes.
Right? That's what I'm saying. Headlining it saying that people think that like, you know, what's the name of someone that's like a leader in pain perception and research now?
James Lowry. I mean,
yeah, those people, like all these, and he's studied a lot more in depth. And I think, you know, as pelvic floor PTs, we have to understand pain a little bit better. And rehab people, anybody, doctors, nurses, we have to understand pain a little bit deeper, just because, you know, people come in the door.
And that's the first thing they want taken care of.
Yeah, they come in the door for that, you know, and it's just like just understanding it better and relating.
Yeah.
And time, bringing it back around, has a lot to do with that, so that we can sit and talk and figure out what's going on with it.
How much of what you guys see is all movement, right? I mean, it's Right.
It 1000% happens. I fall off, I break my ankle, it's there.
Right.
But what happens is we get these phenomena that basically our body teaches itself to be in pain as a protective response.
Right.
And it's the inappropriate, that's what chronic pain is.
Right.
You ever stepped on a Lego?
Yes.
It hurts so bad.
Worst.
Not as bad as attack, but
right. Well, tack stays a little longer. Goes away in 30 seconds, right?
Yeah.
It hurts. I mean, it hurts. You know, like I'll get out. And
during that 30 seconds, cut my foot off.
It's gone. Just get it off.
Yeah.
But it goes away, right? Because your body knows. You look down and you respond properly, right?
Yeah.
And it goes away. Well, chronic pain, you have an injury and it sticks around because it's that nervous system acting inappropriately. Now it's scared, it's nervous, it's like an alarm, and it's on this red alert, and it's staying there. So what we have to do is we have to teach you how to calm it down, and we have to teach the nervous system that it's okay. And we do that with movement. We do it with education, breathing, pacing.
Breathing's big.
Knowledge is the most important, right?
Yeah.
So we get these things that
you redirect the brain to think about something else.
Right. Yeah. So we can get super nerdy. We won't just keep it.
Oh, it's all right. I like super nerdy.
So redirecting that concept is like, so people use things like foam rolling.
Yeah.
Right. So the common knowledge of foam rolling is that it breaks down fascia.
Okay.
0% chance of that ever happening.
Right.
Ever.
Never?
Ever. No.
So I just look like a goofball when I'm rolling on the phone?
No, I mean, so what it does is because you feel better when you're done.
Right. Well, sure. I mean, you're working core muscles and things that you wouldn't normally do, right?
Sort of. So you have a calf muscle that's sore, right? It's sore. You rub it out, right, on the foam roller. It feels better.
Yeah.
What happens is a phenomenon or theory called diffuse noxious inhibitory stimuli. Basically, the major pain effect.
Right.
Right. So you create a painful stimulus.
Right.
You raise
more painful than what you had.
Exactly.
To start
so
with.
now your body is responding to whatever the symptom was. Much different, which is what stretching is. So it's all the same.
When I first found trigger point,
the word, 2 words, trigger point.
Well, and the block system and the things that come with it, and I ran my first half marathon after not running ever in my life.
Oh, cool.
And I tried it, and I was like, "Get away from me! There's no way that this is gonna make me feel better. Don't ever touch me with that again because it hurts so bad.
Yeah.
It's very painful,
right?
Yeah.
So 4 or 5 times later, I was like, "Oh, dude, this was good. Where's trigger point? Right?
Right.
So I totally get it. You make something hurt worse, like when I would stub my toe, you'd pinch yourself, right? Or you hit your head and you go kick your toe. It's like you replace one with the other. So I get it. I totally get it. It's amazing what our bodies can really do.
Oh, yeah.
You know,
beyond our comprehension.
Yeah.
Right.
Still.
Yeah.
Yeah. So
yeah.
Okay, so we are kind of getting towards the end of time here, but for both of y'all, where can we send people if they want more information, or if they want to come see you, or how, like actually walk me through your intake process, both of y'all. Like how does it
intake process? Okay, so you could either find us online at www.inherphysique.com. You go on there, and then you can book an appointment with us online. You can
spell Inher. It's spelled differently.
Yeah,
right?
So INHER.
Okay.
Yeah, so that's how we spell it. And you can book online there. After you book online there, we'll call you and we'll kind of like do a mini consultation to see exactly why you'll come in, to kind of like, stop playing the guessing game and know kind of how much time we need to block off for you. Then you'll fill out your paperwork online or print them out and bring them in. And then you come in and talk with Dr. Justine and do your evaluation.
Yeah.
Yeah, and then we'll formulate a plan after that.
Right.
Treatment plan after that.
So how long does it usually? So let's say I come in and see you. Are you able to usually do a treatment plan after first sitting down and talking to? Or?
Yeah, we get you on the right track. Sometimes it's trial and error, especially if your medical diagnosis doesn't match the symptoms that you're showing in our session. Right. But we can always we do a lot of education. Yeah. So, hey, let's do a bladder diary. If you're leaking, okay, when do you leak? How much?
Right.
food did you eat today, blah, blah, blah. That kind of thing.
Right. So I can come see you one time and at least I'm going to be heading in the right direction.
Right. I wouldn't say just come and see me one time and just go.
No, but okay. So, so on the first time that I see you. So
we're going to make some kind of program.
Yeah, okay. I thought you were going to say prognosis.
No. Not prognosis, because anything can change at any point.
Right.
Yeah. But, 6 to 8 visits or a year.
Yeah.
It depends.
So, because I know I've gone in to see physicians or whatever, and you leave there kind of like, okay, well, what do I do now? And it's like, you don't get it,
And
or you got to wait 3 weeks for the test results to come back or whatever it is.
That's like the worst. Yeah. The worst. But because in Her Physique, we really base our treatment around function. So it's going to be a goal. Mm-hmm. It's not going to, hey, like, let me stop leaking on myself or leaking during, like, no, what is it? You want to have sex with your husband again?
Right.
You want to be intimate with your husband again? You want to go, to work without, embarrassing and leaking through your clothes? Like, we make functional goals that will impact your spirit.
Yeah.
So that's kind of what we do during the first session.
No, that's cool. Because then man, there's nothing better than progress.
Yeah.
That's right.
Right. And then
tangible
you feel like you're winning, like the small wins. It's huge.
Yeah.
So, what about what's your intake process like? Got to throw a tire a couple times?
Same thing. Yeah. So, it's very simple. Schedule online, call, everything's done through my phone, Facebook, whatever. Yeah. It's very simple. We get in, we have our first hour evaluation, a lot of talking, educating, getting to know your history and what's going on. Sometimes it's quick. If I know the patient, sometimes it's a little quicker. I know most of my patients prior to them walking in, just from being ingrained in the community for the last couple of years here.
But yet we've never met. I don't know how this happens, dude. Yeah, weird.
It's bigger than what you think it is, though.
It's not that big.
It's not that big.
It's not that big.
It's not. Never mind. Okay.
It's not that big. So the goal is to have maybe not like a 100% plan, but have confidence that you're going to get better. That's all I want to instill in my patient before they leave day one, especially those that have been in pain for a really long time, that have been demonized by other practitioners. Like, oh my God, your shoulders, blah, 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 your knee is this, and your back is this. And it's like, hey, it's all good. We're going to be fine. Mm-hmm. Yeah. There's plenty of people out there that are quote unquote structurally worse than you, and they don't feel anything.
Right.
We can get there. We can get there 100%. It's just going to take a little bit of time. You're doing the right stuff, or you're not doing the right stuff. Let's try these things. Or I know you're scared to do X, Y, and Z. Let's just do X until we see each other again, and then we'll go from there. Yeah. Right?
And that, CJ, is like super huge, right? Because
just one thing, right? One thing?
Mm-hmm. Just one thing. But also, like, I guarantee you when they're going to the doctor, their doctor is not instilling that confidence in them.
Right.
So, and that's how we get our outcomes.
Right.
Yeah. It's sort of, okay, here's the problem. Here's the treatment. This is what we suggest. Have a good day. Let me know if something's different. Right.
Yep.
As opposed to you get the whole like cheerleader sort of rooting you on and
sort of.
But we back up what we say.
Yeah.
You know what I'm
saying? That's the thing about it.
But and I say these things like this because first of all, it's a huge differentiator. But second of all, I mean, there's some value in that I don't think a lot of people understand yet. I know there's a lot of movement coming around to some of this style of treatment. This sort of, I don't necessarily want to medicate everything, and I really do want things to be specialized and personalized, and so people are waking up, I guess is how you could call it, and see that. So to me, I mean, I feel you. If I got somebody, if my doctor called me on like Tuesday after I went and saw him on Friday, and he was like, hey, checking up on how you doing, that kind of stuff. Oh my gosh. Yeah, it's huge.
Presents for Christmas, birthday,
right, and then knew me by my first name. I mean, that's even better. Yeah. So very cool. Okay, so do you have a website?
It's themovementdoctor.net.
Okay. And then Facebook, Instagram, all that good stuff.
The Movement Doctor. Instagram is _movement_dr.
What's with the underscores?
Well, you can't.
I don't know.
Can't do dash.
Well, it just looked better than like the Movement Doctor straight across. Visual.
Right.
Yeah.
Okay. Mm-hmm. All right. Aesthetics, right? Yeah. Very cool. Awesome. Well, I want to thank both of y'all for coming in today.
Thank you so much.
And very, very interesting work that you guys are doing. Very cool.
Thank you. Thank you.
Something new.
Thank you. Yeah.
So, okay, you guys, you can find us at Picola Radio X on Twitter. You can find us at Picola BRX on Facebook, or you can find us on our website at businessradiox.com or on our live feed at businessradiox.live. This has been Pensacola Business Radio, where business is good and your work matters.